I've picked for you today was... Hi, my name's Helen. The topic I've picked for you today is communication of critical information. So in your prac in ED, you're going to get a lot of opportunity to hear critical information, and this talk's going to be a bit about like finding that critical information and then what you do with it. Part of it's going to be how you seek it from the patient, how you draw it out of the patient, because there's such an overload of information when you're in ED. So as part of the talk, I'm going to explore the framework for communication of critical information, discuss the importance of it, and talk about how you find it. A lot of it is just practice and experience. It's going to teach you to know what's relevant and what's not. And then we're going to do some scenarios where I'm going to pretend to be the patient. You're going to ask me questions and try and draw information out of me. And at the end, I'll ask you to do a quick class evaluation, which is just another tick box exercise. So just a bit about the framework. This communication of critical information comes within the framework of the 8 NSQHS standards. So I don't know how much you know about nursing framework and what you've done in your course, but there's a lot of different theories about nursing framework and the framework we work under as nurses. So you obviously have your laws that you have to abide by. Have you done much about this sort of stuff in your course? So the laws are like the Medicines and Poisons Act and OSH Act and all the laws we have to follow, and you have to be really mindful of that obviously, because you don't want to be breaking the law when you work. There's a regulation of us as an industry, and the Nurses and Midwifery Board regulate us as an industry, and they tell APRA whether or not we're a suitable person to be registered as nurses. And when you do get registered, every year when you get your registration, they ask you a set of questions like, have you had a new, have you been charged with a criminal offence in the last year? Has this happened? Has that happened? And that's because they have to make sure we're a fit and proper person. So that is kind of the Nursing and Midwifery Board regulating us, and then they report to APRA. So that's part of the regulation that that we work under. Then you have your policies, and policy is a decision by a governing body. So if you understand it, they have lots of policies about various things, and in ED they have lots of policies as well. So there's lots of policies that you have to kind of think about. You get lots of reminders. Once you start working somewhere, you'll get constant emails about new policies. An example of a policy that we have here at the moment might be the PPE policy, because during COVID that's been constantly changing. Like a month ago, everyone in ED had to wear N95 masks and eyewear, and now that's relaxed a bit. So we're getting like weekly updates about that. So they're just an example of the policies that we have to work by. A procedure is more, I found like all of this so confusing when I was like learning nursing, not what was what. But, and a procedure is just a set of steps that you have to follow to do a particular task. So it could be on doing a catheter or giving a medication, and they are mandatory steps. So it's very important that when you are doing tasks in ED that you're aware of the procedure, because if something goes wrong and you haven't followed that procedure to the letter, you can be in trouble. Then there are the guidelines, which are, there's kind of guidelines on the hub and for various things, but they're not a mandatory thing. They're more of a suggestion about how you would do something. Sometimes you have a guideline before you have an official operating procedure for something. They might put out a guideline, which would just means it's a draft really, and later on they'll have a proper procedure which you do have to follow. And then we get to the standards. So we have standards up in the regulation section. So standards for nursing, we have our standards for nursing practice, and a code of practice, and a code of ethics. But today I'm going to talk about the hospital standards, so the standards that the hospital has to abide by, and they're called the National Safety and Quality Health Service Standards. And there are 8 of those. Have you looked at the 8 standards? Yep. So in the 8 standards, see, this is where our communication comes in. And those standards have only been around for about 10 years, and originally there were 10, and I remember they had falls, that was one of them, and pressure care, I think. And now I think they all come under comprehensive care, so they've simplified it, and that standard's actually really easy to understand. But you don't have that much exposure to them until you're working somewhere where you have an accreditation, and then you'll know about it, because 3 months ahead, the bosses will get out there and they'll start making sure everybody knows their standards. Because if you have an accreditation where you're working and the accreditors come out on the floor, they can just go up to nurses and ask them things about the standards. So that's when you really have to learn your standards. And it's also good when you're applying for a job. A lot of jobs in the selection criteria now, they'll say they'll ask you about certain standards. So it's always good, and they're really easy to find. They're really easy to read. So today we're talking about communicating for safety standard. I haven't got a pointer, so I'm having to use the mouse. I couldn't find one anyway. And in communicating for safety, you have patient identification. Obviously, our 3-point identification is really important for safety for the patient. Clinical handover, so the patient's always under one nurse or another, and you never just walk away and leave your patient without handing them over. Communication on critical information and documentation of that information. So we've drilled right down through so many steps just to get to this one topic. So you can see there's so many topics that surround your nursing practice. So it's really important. What's happened to my PowerPoint over there? When critical information emerges or there's a risk to patient care, timely communication of this information is essential, and it also recognises that critical information can arise at any point during the patient's care. So today we're mainly talking about patients that ED is kind of unique in that when you get a patient, you virtually know nothing about them except maybe 3 lines that's on the triage, and it's really different from other areas of the hospital or other areas of nursing generally, where you're probably going to have a nursing handover. You're going to have a lot of information coming in with your patient. You don't have that in ED, so it's kind of a blank page that you have to fill out. And it's not even like other hospitals where they have like the hard copy notes. And I think it's a good thing that we don't have that here. But when they built this department, they had planned to have a computer in every cubicle. And if you might notice, there are computers in every cubicle, but no one uses them because they're too slow, and you can't quickly look something up. So if someone came in with a hard copy of the notes, you could flick through the notes. But here, nobody really uses the computers because you tap on and that's got to load, and it's a series of steps to get to their notes. So no one really uses them, and it's kind of it's a bit unsafe really, but it also really improves your assessment skills, and you get so good at your assessment skills when you work in ED, especially ED where you haven't got access to anyone's history, because you have to get that history out of the patient somehow, and you've got to glean it from what they're saying, and often they're not very good at articulating what's wrong with them, so you'll find your assessment skills just improve heaps working in ED. So finding that critical information. So today I'm more talking about, so you're working assessment, a patient has come down from triage, you do your A to E, and then you're going to do a more focused assessment on that patient, because you want to find out more about the thing they came in with. And so how to get that information? Well, it's sort of active listening. It's trying to be mindful when the patient is telling you a story. It's really difficult because there's so much noise and activity in emergency. You get a lot of interruptions. I mean, there's no manners in ED. People just come up and just start talking to you, even if you're talking to someone else. Someone will just barge in and start talking to you about something else entirely, or ask you a question. So you've got to try not to get distracted, or you just do get distracted and then you go back to what you're doing. Well, the patient may have a family member with them who's constantly interrupting as well. So you've just got to try and switch off and focus, and part of it is asking the right questions and keeping the patient on topic, because so often they can't articulate what's wrong with them, so you have to try and ask the right questions to keep them on track and find out the critical information. That's all part of our focused assessment. So I'm going to do some scenarios, and I've given you some information, like as part of the ATE, when these patients came in, I've done a pain assessment. So, but I've just written the pain mnemonic on the top of the sheet, in case you've got any other questions you want to ask me about pain. And then I might get you to, it might be better if you work in pairs, just to try and brainstorm some ideas about what questions to ask me. You underneath so you know what you're doing. Alright, so I'm a 25-year-old female. I'm presented with right lower quadrant pain. I've had it for about 48 hours. It's sharp, it's non-radiating, it's worse when I stand up. I've had my obs done there and they're kind of okay, aren't they? So I'm your patient and I've just come down and that's all the information you really have about me. That's what's on the trio. So can you think of any questions that you'd like to ask me? Or do you want to brainstorm together first? Do you want to come and sit over here maybe and just have a group of 3 and a group of 2? I don't know how you want to do it. Something like this maybe, yeah? Do you think of any questions that you'd like to ask this patient? So I'll give you 2 minutes just to think about it.
Are we writing this down? Are we writing down our
If you want to write it down just so you remember what to ask me, you can write it down separately or you might want to brainstorm together.
That's not right.
Alright, you ready?
Yeah.
So has anyone got a question for me?
Is there any chance you're pregnant?
Possibly my husband and I have been trying to get pregnant and I'm not on the pill at the moment.
Then from there you can ask when their last menstrual period was.
About 6 weeks ago. So I've missed a period.
And then you didn't take the pregnancy test?
No, I haven't taken one yet. I've had a bit of spotting, so I kind of thought I was getting my period. But spotting's not normal for me.
Have you ever had this pain before?
No.
When was your last bowel movement?
I had my bowels open today and it was normal.
Are you currently on any medications?
No. Just well and healthy. Just been taking Panadol for this pain.
Are you having any nausea or diarrhea?
I have had a bit of nausea the last few days, or actually the last week or so, and I've been off my food a bit. But no diarrhea. Just normal.
I'm not sure if it was asked already. Did the Panadol have any effect?
Yeah, it does help a bit. It's about, my pain's like about 5 now, and the Panadol brings it down to 2, but it just kind of comes back when the Panadol wears off. Questions up the back? How's it all? Yeah, that's really good actually, good questioning. Alright, so I'm going to go through some of the things I would ask, and when you've got an abdo pain, obviously it's different if it's a man or a woman, so any woman within childbearing age, you definitely ask all these questions because it's different. Bowels, urine, that's really good. So these are the ones that I had. Yep, you asked me when my last menstrual period was. I told you that I had some spotting. sexually active, because as soon as you've done this, you're going to go and test her urine, aren't you? You're going to get a urine test, you're going to make sure she hasn't got a urinary tract infection, and you're going to check her for pregnancy. So if you've asked me if I'm sexually active and I said no, would you still do a pregnancy test on me?
Maybe, I would say so. My
Yeah.
opinion would be.
They lie. And it might be like a 16-year-old with their mum too. So you always do it. Alright, pregnancy test. Yes, I've got some nausea. I've missed a period. You didn't ask me directly about urinary symptoms, did you? So that's another thing. Any abdo pain, just ask if they've got any symptoms of a UTI, so any burning when you wee or frequency. So no, I haven't had any of those. My bowels have been normal. I haven't really been feeling unwell, just the nausea and the pain. And I've had a bit of a reduced appetite because of the nausea. So there's one more question that I would ask the patient in this situation, and I ask pretty much every patient this, and with a triage, and when you triage you just do constant assessments all day. And there's one question that I feel like not enough nurses ask, and even doctors don't always ask. What do you think? There's one more question that you could always ask. It's not just an abdo pain, it's pretty much anyone that comes in with anything. When you're thinking about their medical history.
What do you think you
Sorry?
What do you think you have, or what do you think?
Yeah, you can ask that, yeah, because often they come in with, like, especially people with gallstones and stuff like that, they've had it before, you know, they'll know that it's the same, or they'll tell you it's different. So the big question that I always ask everyone, any previous surgeries? So, oh yeah, I had my appendix out when I was 12. It kind of changes the story, doesn't it? And the thing that happens with women, especially with right lower quadrant pain, if they haven't had their appendix out, they just get handballed between surgical team and gynae. Because what would gynae have this patient for? What would they be thinking was wrong with her? Can you think what would be wrong with her? What's causing the pain? Yeah. Because she's possibly pregnant, she's got symptoms of pregnancy. She's got pain where her right ovary would be, or right fallopian tube. So it's I always ask them if they've had any surgeries. Because you don't, at that point you haven't looked at their belly or anything to look at scars or anything. You're just like doing a quick A to E, asking them a few questions. We don't tend to feel their belly in ED, the doctors do that. But I always ask them if they've had a surgery. So this patient, this would kind of change that patient's journey, because she would now, like surge wouldn't have probably get involved. She'll still need an ultrasound before gynae will accept her as their patient. But we also know now that she's quite a high risk patient. She's got ectopic pregnancy. They'll probably kind of fast track her ultrasound. So that bit of critical information will change the patient's journey. So who do you tell? As students, you just tell the nurse you're working with, I guess. Once you're a junior nurse on the floor, it's a bit intimidating telling the doctors, this is information the doctors, so this is me as a senior nurse, I just give the doctor a heads up and say, my lady in 36, she's got the right lower quadrant pain, she's pregnant, by then I probably would have done a urine test on her, and she's already had an appendix out, so that gives the doctor a really good idea of what might be going on, and he might, if he had another couple of patients to wait before seeing her, he might change the order of things and see her first, because she's all of a sudden become kind of a high risk patient. So that's a really good example of where critical information can change the course of a patient's journey, and it can save lives. And it probably should have been asked at triage, but might not have been. So you know they don't always ask that at triage, and like I said, you've got so little information. Alright, so you tell the doctor, this is the thing I have to keep going back to because of the course I'm doing, because it's about communication. Tell the doctor, if you're too intimidated to tell the doctor, just tell a senior nurse. Area lead's really good. Document what you found, and document that you told the doctor. Okay, and the doctors are really approachable here, but they're approachable. I remember the old days when like the consultant walked around with the team and you couldn't like just go up and talk to the doctors. You had to go through the senior nurse who would then talk to the doctors. But the doctors in NPD are really approachable, but I feel like they're approachable because we don't waste their time much. You know, we kind of only bring to them the stuff that they need to know, and you'll just get to know what that information is after a while. Alright, next one. 36-year-old male presents with red, painful right knee. I think I've made a mistake in there. He looks unwell. I think I've written he looks well.
Yeah.
He looks unwell. His other odds are normal, but he's febrile. He's got a fever, hasn't he? He's got 8 out of 10 pain, and these are really painful when they get infected or anything goes wrong with them. Worse on standing, worse when he bends it. Doesn't radiate anywhere, it just feels like it's right inside his knee. Any questions you want to ask me? On this 36-year-old male?
What happened when it happened, like when it
Yeah,
started?
was it an
what
injury?
were you doing?
Yeah, well, that's the other thing. Now, when did it start? Okay, it started at 48, about day before yesterday, but yesterday morning it started getting a lot worse, and I couldn't go to work yesterday, and now this morning it's really red.
Is there any swelling?
It is swollen. So the swelling's just kind of gradually come up over that period. But yeah, if you were talking about injuries, yeah, I would ask the person if they injured it. Did you fall over and land on your knee? Because a lot of the time they'll come in with a sore knee and they don't think to tell you that they've actually like hit a door with it or something like that. The other thing you can ask them is, have they been out there? Because it could be a skin infection, so it could be just cellulitis, so it could be like a surface infection. And have they been in the garden on the weekend? You know, maybe it's like a Monday morning, and they a common thing that can happen is they get a thorn in one of their limbs, especially if it's right near a joint or a bone, and it can just blow up an infection really quickly. Anything else you want to ask him? You'd ask him about the neurovascular. Obviously, he's got any tingling or numbness in his foot. Anything else you don't want to ask that patient?
Any history with surgery?
Any history with that knee? Well, funnily enough, he didn't think to tell you, but that's what his knee looks like inside. Because 10 years ago he broke his leg and he's got his metalwork in there. And they're notorious for getting infected when people have got metalwork in their body. And I worked at Silver Chain for a while, Silver Chain have, and they, so I'm doing community nursing, and the stuff you see out there is incredible. Have you done any community nursing ones? Because the stuff people are living with in the community is just horrifying, but you do a lot of work with infectious diseases, like a lot of their patients are infectious diseases patients. And I didn't even know what infectious diseases did. I thought they did studies on measles and that sort of stuff, but they don't. They treat patients that have really resistant bacterial infections, and because you know how you talk about superbugs now, so they treat patients that have these superbugs, and they are on these like super strong antibiotics, and you've got to get permission from like Canberra to even use them, and it's really heavy stuff. And they have antibiotics for years and years trying to get rid of them, but other patients might be patients like this who get an infection in their bone, which is really hard to treat, and it's really hard to get rid of it. And I had because you know, you've got no circulation in there, and the antibiotics and the white cells and everything can't get to where it is. And I had a patient who was in his 60s. When he was in his 20s, he was working on a boat and he smashed his knee, and he had to have like a full knee replacement. And then he went for 40 years without any issues, and then it just suddenly got infected. And it's really awful for him, because bacteria, it's a really great place for bacteria to grab onto when there's metalwork in someone's body. So that's what I would avoid it as a young person at all costs, to be really careful with yourself, don't break any bones, because you end up with that metalwork, you've just got that vulnerability in your body for the rest of your life. So this guy, they couldn't get rid of the infection in his knee. He had a year of antibiotics, couldn't get rid of it. They ended up having to take the metalwork, so take the prosthetic joint out of his knee and just throw it away and put cement there, just to keep his blood, top of his leg and his bottom of his leg together, while they treated him for another year, trying to get rid of the bacteria that he had in those bones. And they finally got rid of it, and then he was going to have surgery to take the cement out and put a new knee in there. And it was just like 3 years of hell for the guy. So you've got to be really mindful. So if his knee has blown up suddenly, he could have an infection in that bone, which is serious. And he's already got a fever, so it's 38. He's unwell, so he's probably getting septic. So that's kind of critical information that the doctor probably should know. You know, you've got a patient with this red swollen knee, and you haven't seen this yet, but he's told me he's got metal work in that knee, so it can be escalated then. It's a bit of critical information that stops him sitting there for another 3 hours waiting for a doctor. Right, I think I'm gonna have to skip the kid one. So who do you tell? The senior nurse. And how do you tell them? You document it, and then you document that you told someone. I'm just going to skip the boy for a minute, just in case we don't have time, because kids kind of opens up a whole other world, doesn't it? Okay, 30-year-old female presents with epigastric pain for 3 days. Her obs are okay. She's actually a gym instructor, so this is a lady I had in assessment once, so I kind of remembered her because it was a funny story. Heart rate's 90, which for a super fit gym instructor, you'd expect maybe she'd have a lower heart rate, but she's in pain, so that could account for the higher heart rate. It's still within normal limits, nothing special. Blood pressure is normal for a fit young person. If she's not febrile or anything, it respirates up a bit, but she is hunched over. She's got a lot of pain. It's sharp, non-radiating. It's much worse when she drinks cold water. It really sets it off. Hasn't really been eating because of the pain, and the analgesia doesn't do anything for her. What questions would you ask her?
Maybe she has indigestion, like if that's something that
Yeah,
happens
that's
for
a
her.
good one, because she could have reflux. It could be something to do with her stomach. She could have she could have gastritis for sure. Yeah.
Has she ingested anything that's abnormal in the past 3 days, like
That's a really good question.
medication or food or an object or?
Yeah. No, I've just been having Nurofen for I've got a sore knee at the moment. I'm a gym instructor, so I've been taking Nurofen to get through that. Actually, I wish you hadn't asked in that order. It's kind of blown my big reveal now. So I'll continue on with it. I just want to say that any female in childbearing age, even if the pain's up here, I would still do all of those tests on her. I'd still ask her about pregnancy, because she could have had a ruptured ectopic. So she could actually have free fluid in her abdomen, which is now irritating her diaphragm and causing this pain here, but it probably she may not have got to that stage without having other symptoms first, but it's possible. So you would still do like all the pregnancy questions and do a pregnancy test on her and check her urine and stuff, just because you just do that with any young woman with abdo pain. No, in her case, I kind of went through all of that with her, and then when I asked her about any surgeries, so we got to that point, and I said, have you got any surgeries on your belly, or I just kind of ask everyone about surgeries, because they'll say, you say, have you got any medical history? And they say, oh no. And you say, have you had any surgeries? Oh yeah, I had a heart operation 10 years ago, but that's been fine, but so you actually have got medical history.
Yeah.
And if it's a long time ago, they tend to forget all about it. So if you ask someone if they've had any operations, broken bones, it kind of brings it all back for them, and it's often relevant, like they go over the knee, that's really relevant information. So in her case, I asked her if she had any surgeries, and she said, I had a knee reconstruction. I blew my ACL, and I had a knee recon 3 months ago, and I've only just gone back to work. And my knee's been really killing me, so she's got a second pain that's kind of been forgotten about, no one's even thought about that. So often you can say, you ask me if they've got pain, she says, oh, 10 out of 10, and have you got any pain anywhere else? Well, yeah, actually, yeah, she's got 7 out of 10 pain in her knee. And it turns out, she said, I've been taking Nurofen before, but it's not helping. And I said, well, how much Nurofen have you been taking? And she said, at least a box every day. So, and then I was like, that's the critical information, isn't it? Because it's just eroded her stomach. And when I went on to the bowel questions, she actually had dark stools. So she had eroded her stomach so much that it was actually bleeding. And she was having dark stools because it wasn't quite believed. She didn't say black, but it was dark. So she was potentially in a lot of trouble. Because that's, have you ever heard of the 4 abdo pains of death? So there's 4 abdo pains that they say when you start triaging, I might talk about this, that there's 4 abdo pains that can die while you're triaging, basically. And that's one of them, gastric bleeding. They can really be bleeding a lot, and it can happen so quickly. So she might just be having a bit of a niggle now and her stomach is bleeding a little bit, but it can just start to bleed a lot. And the other one we do is ectopic pregnancy. So that's one of the abdo pains of death because they can die in the waiting room. And the other 2 are, anybody got any idea what the other 2 might be? I'll let you have a think about that and then I'll ask you at the end, okay? And there's 2 more. So she was, So who do you tell? Well, you definitely tell the doctor about that one because that's a really critical bit of information. She's wrecked her stomach and she'll recover. She's got gastritis is a really hard pain to treat to start with, and the only thing that fixes it is just time. And so she'll be like a week or so, just trying to get on top of that. So maybe I will do the child. No, not really. Right, anyone want to have a guess at the other 2 abdo pains of death?
Triple A?
One's an injury. One might be like a footy player who comes in from a game and he's got a knee to the abdomen and he's come in and he's like, oh, he's a bit pale and not looking right. Give him a bit. Give him hints.
What were the first 2 you said?
Sorry?
What were the first 2 that you said?
Ectopic pregnancy and gastric bleed. And the gastric bleeds are really, really common, Denise, with the older people because they're on blood thinners. If they're on blood thinners, and with old people, their bowel and their stomach is just so friable and delicate that they might just eat something that irritates their stomach, and whereas normally it might just irritate you to have a little bit of a bleed and it would clot, and all that don't clot, so their stomach just keeps on bleeding, and that's really common. And they often don't come in until they're like having the black stools like the next day, and then their gut's just bleeding.
Your appendix bursting?
Sorry?
Your appendix bursting?
No. It's a good guess though. No, they don't tend to bleed so much. They just kind of rupture and get infected from the appendix. They do rupture. They're all bleeding things. So what are the big blood vessels that you have in your abdomen? What's your biggest blood vessel?
Is it triple A one?
So your biggest blood vessel is your aorta, isn't it? And people kind of think about it being up here, but you forget that it actually goes like straight down the middle of your body. And if it gets an aneurysm on it, you can be walking around with an aneurysm for a long time and not even know you've got one. And you can be a relatively young person because they can be hereditary. So people just wander around with them, not even know they've got them until they burst. So they die really quickly. And the other one is a ruptured spleen. Yeah, that's it. So that'll be the person that comes in with an injury. They've got pain here, and they can die in the waiting room as well. Alright, so just a bit of a recap. So we talked a bit about the nursing framework, that critical information comes under. Oh, why is it not come out right? We talked about the context that critical information comes under the health service standards within the nursing framework. And we talked about finding critical information and active listening, asking the right questions, and it's all about the focused assessment, and we did some scenarios and that asking the right questions. So just pretty much every patient, when you ask if they've got any medical history, just say, they might tell you a few things, but then say, have you had any operations and have you ever broken any bones? I always ask those two things. And it reveals heaps, you know, you learn a lot from that. Because you might have someone come in with right upper quadrant pain and, you know, it sounds like gallbladder, but they've had their gallbladder out, but it doesn't mean they're not gonna have, because you can have this syndrome after you have your gallbladder out, where they just have ongoing pain and symptoms where it was, so you can still have those symptoms. So just, if they say they've had their gallbladder out, don't think, well, it can't be gallstones then, because it can still be, they can still have issues there for a long time afterwards. And that's it, and if you wouldn't mind doing the, thank you so much for coming, guys, really appreciate it. If you wouldn't mind doing the cast evaluations